Thanks very much, everybody, for being here today, for sticking it out to our last session of the day. I'm going to pass it over to our panel members to go ahead and introduce themselves.
Hi, I'm Candace Hansen. Nice. I'm the executive director of Canopy Roots and Canopy Mental Health Consulting. It's two sister companies. We provide treatment services in Minneapolis and St. Paul, and we also administer the Minneapolis BCR, Behavioral Crisis Response, in the city of Minneapolis, as well as the ERT in Brooklyn Center, as well as a program out in LA that we just launched. We focus on providing behavioral health responders to answer calls that are related to behavioral health that come through 911. I'm the former program manager of the Minneapolis BCR, so I spend a lot of time talking about that program.
Hi, my name is Grace Wolf. I'm the Vice President of Crisis Services for Detroit Wayne Integrated Health Network in Detroit, Michigan. Thanks. Detroit is a very unique place. When I arrived there a year ago, they actually did not have any components of the crisis continuum, as you would expect a major metropolitan area to have. So in the last year, we have launched a 24/7 crisis call line that covers Wayne County, 24/7 mobile crisis that covers Wayne County, and a 32-bed crisis facility. So it's been a busy year, but we're very excited to offer the crisis continuum to the citizens of Wayne County, and excited to talk a little bit about how we work with the other agencies in the county.
Good afternoon. My name is Lindsay Fox. I'm a physician assistant, but I'm also the director for the Center for Inclusive Health at the University of New Mexico in Albuquerque. Our center is unique. We provide street medicine, and I'm curious, how many people here have heard of street medicine? Wow. Okay, that's great. And we also provide research and policy development. The reason I'm here today is, for a lot of us, I think we share this, is with Mariela. And about 3 years ago, she came to us and said, we believe there's a role for street medicine in ACS. And at first I was a little like, well, tell me more. And what we've realized, along with these other service providers, is that there is a role for street medicine outside of medic care. So, like, I think of paramedics, I've heard a lot of people talk about that, but we are all MDs, PAs, psychiatrists, psychologists. We all are board certified in addiction treatment and mental health. And so we're responding in real time with ACS as an alternative response to giving care to folks mainly living on the street and in unsheltered areas. So I'm excited to be a part of this panel. Thank you.
Awesome. Thanks a lot, everybody. So today we've spoken a lot about, if only we had access to this or that, or obviously the housing that kind of comes into play every time we talk about the needs that we have for the community. What's exciting about this panel is that we're going to speak about some of the needs that have been addressed. So the systems that we've tied our emergency response system into. And so we've got obviously a number of folks here who, from the for-profit system, nonprofit, from the university healthcare system. So we're hoping to get a bunch of different ideas and perspectives on how that works. The first question I'm going to start us out with is, how do you identify some of these other systems outside of your specific response that you'd like to tie into as kind of like a formal relationship between your response and where you're taking somebody or who you're connecting them with?
I can speak to that. I think in Minneapolis, there's a lot of resources. There's just a ton, and it really is about connecting folks to them. And so first we look at, like, what are the different sort of types of care that the people that we respond to tend to need. So there's our number one, our crisis county crisis stabilization services. That's one that we connect to pretty often because they can do 10 days of stabilization after we respond to a call. We connect to them pretty often, and typically the people that are our service recipients do need that service or can benefit from that service. Sometimes there's some accessibility issues there, but we do work really closely with them. We also find that, the people that we end up taking places to are doing warm handoffs to. So that would be local crisis residences as well as sometimes hospitals, although that's more rare, as well as local clinics that tend to have openings. We have staff on our team that all they do is go around and figure out what are the resources, who has openings, because it's such an important part of understanding what's next after an emergency response, because we do purely 911 calls. The only way to access the Minneapolis PCR is through 911 calls. And so there's this piece of we're just emergency, so we have to be really connected in to the local services that we would typically step down or step up from an emergency call.
And I think going off of that, Detroit took a different angle. Instead of saying, hey, let's try to write a bunch of MOUs, which go through a bunch of legal departments that no one ends up signing, and it becomes about who's in the meeting and who's in the room. Detroit said, we're just going to put it all under our roof. So we operate the call line for the county that dispatches our mobile crisis team that can refer to our crisis stabilization unit. And so that way, it's less about the politics of it all, and it's less about whose signature can I get and who can agree to do something and who wants to share files. Our electronic health record, when the crisis call comes in, they go into our electronic health record. Our electronic health record dispatches our mobile crisis team. They accept it through the electronic health record, et cetera, et cetera. So by the time they make it to a crisis stabilization unit, you have all of this really wonderful and beautiful information from all of the steps they took before. Whereas if you are operating in these silos like people often do, where one agency runs the mobile team, one agency runs the crisis stabilization, you never really get a clear picture of the crisis from start to finish. So I think for us, we said a little bit of like, we're tired of the red tape and we're just gonna rip the Band-Aid off and just do it all.
I have a question about that. Mm-hmm. Who approved that? Like, how did you have the authority? Who had the authority to do that?
So I was actually brought to Detroit to open their crisis stabilization unit. I'm from North Carolina originally, and they brought me in to assist in opening their crisis stabilization unit. I got there and with fresh eyes looked around and said, this is a major city and y'all have 911 sending police to go to your ED, and like that's your behavioral health crisis system? Like that's it? I just launched in rural North Carolina a full continuum, and y'all are sitting here in Detroit looking at me like this? And so my mouth is what got us there, because I said, y'all are doing this completely wrong. You need to have these things. And they said, okay, well, then you do it. And I said, ooh, that's actually not what I meant. I meant like in theory, people should have these things. So I was hired to open one facility, and I now have 3 facilities, a 24/7 call line, and a mobile crisis team, because I was like, if you're going to do it, just do it right.
That's right.
That's amazing. I really hold space for the partners that I work with, and they talk about mobile crisis. I divide what we do into 2 very specific domains. One is street medicine is really geared towards crisis averting. And with the ACS team, we talk about that a lot. So we do a lot of proactives. And what that ends up happening is we've seen over time with our partnerships that the crises, whatever that looks like, has decreased. We all know that when you go into crises, it hits a part of your brain, and with people with trauma. So our whole adage is, let's try to manage this before it becomes a crisis. And so we do that through somewhat neighborhood medical. We have vans, we have trucks, we have teams, we put backpacks on, we walk through, we get to know people, they get to trust us. And so when the crisis does hit, they know it's, I'm a PA, but they call me Dr. Fox. Fox is showing up, or Dorley's showing up. And that gives the people that are experiencing that the knowledge that it's not some unknown individual. We partner with ACS as sort of our community responders as well, and so their team also brings that. So we've seen over time in our relationship with the Albuquerque Police Department that those behaviors, those rounds, those actions have decreased arrests and ultimately decreased incarcerations. And the last piece is my hospital or our healthcare system took over the jail health. And now what we're seeing is I'll see Bob that I kind of met and team up with ACS, and maybe something happens and he does become incarcerated. I now have places I can say, hey, keep Bob on his LAI. And that has created this terrarium, this ecosystem of Bob is just not some dude living on the street on Golden 2nd, but he's a patient of the street team in ACS. And that has really started to change the narrative. So we're trying to foment that through ACS right now. And so crisis, I was a medic for many years. I don't have enough cortisol in my kidneys anymore. So that's why I've really chosen street medicine as proactive, and ACS has been our partner in that.
Thanks very much. And Lindsay and Candace specifically here, you spoke a lot about kind of developing that on-the-ground knowledge. Is there a process that your organizations have where you kind of systematically collect it or review where you're at to see if there's maybe additional services that you need to build into your system?
I'll start. Our services operate a little bit differently. If I had to, we're in the process of expanding, so we're actually going to be adding more peer support and people with lived experience. We believe that is really what foments that relationship. We're also adding social workers as well as psychiatry. We now have a psychiatrist that goes out with us almost 3 days a week, providing real-time psychiatric care and not, so that's important. But really, Candace, I think you had a great statement, so I'm going to let you and I were talking earlier, but yes, this continuing to build out. We say in street medicine, we are not patient-centered. We are patient-led, which for so many people, that is an important knowledge, letting the patient make the decision and keeping the agency and the autonomy within safety. And that really changes the paradigm on how you care for folks.
Yeah, the way that we do this at the BCR in Minneapolis is about having it dedicated to one person, where it's like that this is a central part of their job where they're always looking into it. But also one of the things that they do, a part of our process, is they are going to our staff meetings that we have on a weekly basis, and they're saying, hey, what are the resources out there that you guys are hearing about and that you guys are accessing and hearing about from community members? And so it really is like very much an informal process where the person who is responsible for it kind of gets to use their creativity and use their connections and relationships to find out what's out there, and also to develop relationships so it makes it easier for our responders to access, because sometimes it's about who you know, right? And the relationship that you have with these organizations, where some of these beds or spots might not be as accessible if y'all didn't have that relationship. And so we really kind of keep it people-based. So, yeah.
Awesome. Thanks very much. And, we are a university, so I'm going to keep drilling down this conversation about data. So far, we've mentioned bed space is one data point that we're actively kind of keeping tabs on in the community. What are some other data that you guys are accessing and thinking about as you're making these decisions on who to partner with or how to grow the systems that you've brought in-house?
Yeah, I think data is really important, and we all talk about it a lot. It's how a lot of us continue getting funding. It's how a lot of us get buy-in from local leadership. But I think a really big piece of it that we don't think about is really this idea of people make data requests sometimes for the sake of making data requests, it seems. I was just talking to a group from Wayne State last night about how we had a request for length of stay to be stratified 8 different ways across different insurance types, across longest, shortest. I even had mode thrown in there. I don't know how the last time y'all used the mode, but that's just, I was like, how is this relevant to me providing this service? I also had to Google that because I forgot what it was. And I think that something that this group could really hone in on is that we talked about at an earlier panel of like, what is the evidence-based data? What is the bare minimum data to start collecting, and have it be consistent? Have us all call it the same thing, have it all be measured the same way. That's a huge piece. Are you measuring your data through claims or are you measuring data via your actual forms and your electronic health record or manually? And I think for us as a group, getting kind of what is the best course and how we all measure it and have it be consistent. Because my length of stay or my response time is your response time from when the dispatcher answered the phone, when they hung up the phone, when they actually assigned the case, or when the case was accepted, or when they drove out of the lot. What is your response time? Where does the start and the stop? And until we as a group decide what that is going to be, I think that cross-comparing each other's data across cities and counties and states doesn't really hold as much weight as it potentially could.
Yeah, I think about data as being an opportunity in our programs, specifically, in the Minneapolis BCR, because when we first piloted the program, we actually lost our data team when we transitioned out of being a pilot after the first 2 years, and so we really didn't have anyone dedicated or like budget-wise to really working with that information. And it's been really nice since we moved to Fire. They've started like working with the data again and trying to figure out what we want to see and what we want to gather. Prior to that, we really had just been focused on gathering information about each call to ensure sort of like the effectiveness of the response for us as clinicians, right? Like, did you based on this client's presentation, this community member's presentation, which involves their self-report observations, things like that, and then based on that, what were the interventions that you used, and then what connections did you make, and sort of looking at, was that coherent, did that make sense? And so that's really what we have focused on as an organization. And however, right now there are some smart people working on it at Minneapolis who are trying to kind of build that out further and try to figure out what kind of data can we find that is going to really tell our story and show the impact that we're having.
On our side, what we've been doing is we've been using a lot of ICD-10 codes, which are diagnostic codes within the medical record. And since November of 2023, we can now bill for services through Medicaid. And so what we've been doing with other street med teams around the nation is bundling the codes. So if I diagnose someone's psychosis with methamphetamine use, it'll correspond with what's going on in Minneapolis and what's going on. So as a cohort, we can start to see, are we all calling it the same thing? And then what the response is. So a couple of pilot projects that we've partnered with ACS and Albuquerque Police Department is looking at the interventions that we've committed in terms of sort of the ACS response and the UNM mobile medical team. Is that reducing the number of times an individual is arrested, along with how many times they've used EMS and how many times they've gone to the emergency room. And categorically across those three domains, we've seen improvements in diagnosis. So now people are getting appropriately diagnosed and we're getting the treatments on board. And then the response is dictated to almost that treatment. So I don't track what time we go in and out. What we're tracking is the prevalence within the community and the actual reduction of use on our delicate systems of fire, rescue, and the patients, for some of our high acuity, reducing their visits into a carceral system, which I think over the long term is really a huge win.
I also will add a little something that's probably different about our programs in terms of the information that we gather and how we do reports. So It's controversial, but the BCR actually does not have client-based documentation. We do report-based documentation, very similar to other, or incident-based rather, similar to other first responders. And that might change at some point because kind of being able to pass that information might be more important at this time than more so than it was when we first rolled out as a pilot. But basically, the idea was that we are gathering information about the patient's presentation to try to figure out if that makes sense for the interventions and the connections that we make, but really not tying it to a person where it follows the person in different systems. And that was a calculated thing that we decided to do early because of building trust with community, that this is like a very low commitment response. Engaging with us doesn't involve like this big gathering of information or this big commitment of, let me see your ID, let me figure out who you are, and, put you in this database. And, but then that also has some downsides for, continuity of care, right? So, which is why I say it probably needs to change in some form as time passes. But in that situation, it's a little bit different because we're also not charging insurance. So we're really looking at it as we're first responders, and it's sort of like if the police show up at your door, you don't get a bill from the police. And often the interventions that we do, they might be clinically informed, but they also might be like totally just problem solving based on that person's very specific situation, as well as de-escalation, which also is not necessarily a billable activity, right? Not to mention all of the assessments that have to go along with that bog down responders' time, and also, as many of you clinicians know, burns clinicians out. So it was a unique system meant to minimize the impact on responders, but also kind of like not require community members to have to give a bunch of information about themselves or really commit to this interaction any further than they wanted to, especially if they are experiencing, especially if there's obviously a lot of mistrust in the system, right? So, yeah.
I'm sorry, I have 4,000 questions about that. My electronic health record brain, I think, just broke.
Happens a lot.
Yeah.
Happens a lot.
So the two that I'll keep it to would be, what does that look like for your warm handoffs? Like you said, you're referring to crisis stabilization units, you're working with other community entities. How does that work? And then the flip side of that, does your team, even though it's incident-based and not person-based, if they're going out and that person has had previous incidences with your team, is that still linked, or is it just you have a bunch of separate incident reports, for lack of a better term?
We do that on, our team is still so small where we can do a lot of verbal discussion about folks. Sometimes we have our own internal encrypted email and communication system where we can talk to each other about community members that we see, repeat callers that we see. If we need to kind of say, all right, this person needs a little bit more intention, right? But it's still, and it's going in that report, it's going in our smart sheet, but it's not based on the person's name. It's based on the call. And so, in CAD, you have the CCN number is what we use, and it's always connected to that CCN number, which is connected to an address. So there's still a way to find it and possibly find out who the person is. And we as a team are still small enough to do that verbal kind of collaboration. But yeah, it is challenging to be able to kind of have that continuous care even within our team and outside too. But your first question was what though? I forgot that one.
What does that look like for your warm handoff to other entities?
So the warm handoff is literally that, we are standing in front of them, handing them off. And so it's a verbal, right? And so we document in our documentation that says we sent them to this place, we connect with this person, this is where they're going next, right? But all of that gets delivered in person verbally. We're checking in because we've driven them there, because our service also has a, we can transport folks, and we transport probably on about 40% of our calls. And so we're taking them somewhere physically. We're giving a verbal report to the people that we're handing them off to. We're documenting our side. They're also documenting their side.
Awesome. Lindsay, I have one follow-up question as well for you real quick. So the information that you're getting on your high-frequency utilizer population, is that coming to you, or are you giving your information to another party who's then evaluating what the impact of your services is on their frequency of contact?
That's a great question. I think there's two parts to it. One, when we partner with ACS, that data is, and I don't know if Jody's here. Jody, yeah, there she is. It flows through them, and then our teams collaborate on best practices. So I think that has been really helpful. And then my report back to ACS and to the stakeholders at my university is showing really how these interventions and partnerships have reduced high calls for service. What it's been an opportunity is to really unpack why those have been high calls for service and really start looking at patient-led, patient interventions that just go more than, we've called the medics every single time and the person refuses transport and they're still doing it. So how do we break that down, and how do we look at that from a more metacognitive level? The other thing that I'd like to say about that data that we have also been using and really expanding the scope of community safety is our ability to team up with ACS and go into the communities and meet with folks. We are starting to be able to measure trends within the healthcare world that actually directly can affect the safety of our community members. So one of the things, here's an example. New Mexico is famous for all sorts of things, but one of the things we're most famous for right now is we have the highest rate of syphilis. We've been tracking that. So part of our safety plan is making sure people are cared for and we get treatment to them. The other thing we've been able to see is we saw a direct shift from fentanyl back to heroin. And we saw it, and ACS and UNM was directly poised to be able to kind of be the canary in the coal mine and be like, yo, we got to pay attention to this. And so that data has really helped informed how we care for people on the street. It's really fascinating. For those of you who may not know, there is a huge fentanyl supply chain, and it was disrupted. And so that's why OG heroin came back. And what comes back with OG heroin? Anybody? Are any of you old enough in this room? Bam, HIV. So now we're seeing an increase in HIV rates. So that's the data, and that's when I think about safety of everybody. So how do we think about that in terms of public health? So that's the other data that we use, is to work with ACS in our city and really making sure people get the right care, so.
Yeah, awesome. Well, thanks, Sharon. I want to move us forward a little bit and talk a bit about your innovation, how you think about innovation, and kind of the process that you have for deciding new directions that you might want to go or might want to take your service to the community.
I think this is what we do. We spend a lot of time talking to a lot of people about the things that they do. We can obviously learn a lot from each other. So, we have whole teams dedicated to a whole team of people. TCD, he's here. He's sort of like my right-hand person for this sort of thing, but building relationships with other cities, building relationships with universities and researchers. I think these are having that openness and being able to say, hey, anybody can comment, anybody can suggest, anybody can support, because the minute you start for something this kind of new, integrating these sorts of things and seeing it as it's into public safety and seeing it as public safety, the minute you start getting into a narrow way of thinking, I feel like you've lost at that point. And for us, it's about staying open-minded and being able to pivot quickly, but then also kind of always having conversations with people from every different part of the country about what they do, and keeping those conversations just open and sharing of information is really important to that innovation. I also think too, like, part of, for me as somebody who runs a private company, I think about a lot about recruiting. I have, a big part of our mission is to do this work, but do it well, right? And so I'm always coming across folks. I'm like, oh, you know what you're doing. You got some thoughts. All right. If you ever want to come work here, let me know, because there are some really smart people out there, and people who are really innovative and think outside the box, and wanting to recruit and have people on my team who think outside the box as well, because this moment requires it. We're going to keep repeating the same mistakes of the past until we start letting reality and the present moment change what we do. And so staying connected to those people, like Mariela, having these conversations about, from different perspectives, we just try to keep that going.
I think for Detroit right now, I don't know that we're at innovation. I think that our crisis continuum will reach a year old next week. So we are very much in the foundational period. I feel like we really decided to draw it back and get back to the basics. And so we need time to get that all right and feel really settled and make sure that we have a good handle on all of these massive programs that we opened within a few months of each other. And then once we get confident in that place, then we'll move to the next step. So I honestly, I don't think that there's a problem with making sure you're doing the basics correctly and making sure that you're doing those foundational things, and then moving on to thinking new and outside the box and all of those pieces. So I think both are important.
There's a couple of different areas that I'm thinking about, and one was really catalyzed by being here today, and it's about data and outcomes. Street medicine operates in a weird zone in that we primarily care for precariously housed, unsheltered folks, and the majority of care, evidence-based care, completely excludes that population. So sometimes I walk out and I'm doing stuff that if I told my attending, she'd be like, well, that's not in the evidence. And I'm like, we're not in a house. So one of the things that I'm pushing forward, and I'm grateful to be able to be in spaces like this, is to think about how we can better care for people where they are, and do it in a way that values them as humans, and not be like, well, you don't live in a house. We'll keep giving you insulin and it'll go bad in an hour. How can we switch that, and how can we give them better care? And that's going to require research. So that's something we're doing at the Street Medicine Institute. The second part that I'm super excited about is, in my wildest dreams, I never thought that students, nursing, PA, MD, PT, OT, would ever want to come out with us. And I am blown away. We have the largest student interest group at the University of New Mexico, almost 178 strong. And they all want to do something in street medicine. I'm pretty proud of that. And so, workforce development. To your point, one of the things that always drives me crazy in the notes is, like, I will read some degrading description by some ER doc at 2 a.m. If our team can maybe put humanity, and through education and experience and through language in the chart, that chart hangover you're talking about may just disappear in a couple of years. So we're looking at workforce development, teaching how to care for folks where they are, reducing stigma and harm reduction as guiding principles, as opposed to evidence-based medicine. So those are my two areas. They sort of are synergistically, but I'm super excited being of the generation that my kids keep telling you, yeah, you're the reason we're in this. Well, what can I do to grow the next generation? So, yeah, that's what we're looking forward to.
I love that trend that you're talking about. I've noticed that too. That you know, I remember when I first started working in this field, you could barely get people to join ACT teams when going out in the community, and now, like, licensed providers are not near. They're much more open to going out in the community now. It's pretty amazing.
I like to say street medicine is the cure for burnout. And the reason I say that is because burnout comes through moral injury, and it's when you're existing in a system that commands you to do things that are antithetical to who you are. And with street medicine and being in partnerships that move towards resolution, actually, you just go, oh my God, we can do this. As opposed to, you know, the definition of insanity. Anybody? Yeah. So absolutely, I think this younger generation is being like, yeah, that's not what I want. This is what I want. So let's create spaces within y'all's work for advancing response and bring everybody to the table and say, yes, this is possible. You don't have to follow whatever that was. But it also, you have to be a little crazy. Because I remember everybody's like, you're going to do what? And I'm like, yeah, I know. And they're like, nuts. And I was like, well, you know, what do I have to lose?
Same.
Well, that's a great opportunity here to talk a bit more about evaluation. Obviously, we've got programs in different stages, programs that are just starting. You're talking about kind of moving away from traditional evidence bases that are inside, and even responses that aren't necessarily medical or mental health. It's more problem solving. How do your organizations think about evaluating your one, measuring what you're doing, and two, evaluating the impact of what you're doing on either the members that or the individuals you respond to or the community at large? How do you think about evaluation?
I think that similar to data, I think this is an opportunity for our programs. I know that we right now Canopy has been nurturing an ongoing relationship with a local organization, Minnesota Justice Research Center, and they've been evaluating our program for the last couple of years. And so that's something that has always been really important to us, is like not just doing the work, but making sure it's working. And so it can be very difficult to do that while you're also building it, while you're also sort of like fighting scrappily for every little thing you can get in terms of creating space for that response. So it can be hard to think about that evaluation piece when you're just like sort of fighting to exist. And at the same time, the investment that the city of Minneapolis has put into the work of the BCR and the investment that the other cities that we've been working with that they've put in, it is creating space where we can say, all right, now it's time to start looking at evaluation. And so we get a fair amount of requests for people to evaluate our service too. And so it's just about creating space for that and getting permission for all the things that have to go into that. So
I think that for me, I have a little bit of a controversial take on evaluating the service. We've talked a lot today about 911 integration and police integration, and I think all of those things are really important. But for me, when I look at our crisis programs, my preference is actually that our referrals are not primarily law enforcement or 911. The majority of our crisis calls and the majority of our drop-offs at the care center, our majority of our calls for mobile crisis are not coming from law enforcement, but instead from the community. So for us, 40% of our crisis stabilization presentations are walk-ins, and same thing with our crisis call line. And I really think that speaks to that the community knows that we're there, that the community trusts us, and that they never had to have law enforcement involved in their crisis to begin with. And I think a lot of times people feel like it's the flashy thing to say, like, we have 80% police drop-offs, and so therefore we obviously are making this big impact on the community. And to me, that just says that your police are overly involved in your behavioral health crisis system. And so we've got to flip it, and we have to be more excited about our number of walk-ins that we have. And it shows, especially with a city like Detroit, who does not trust easy, has been burned a lot. And so for them to it be self-referral or, hey, my friend told me to come here, or, hey, my friend told me to call, that means more to us than whether or not we have this overwhelming law enforcement partnership.
I really like that because it's, you know, for my population, it's very hard to send them surveys. For those of you who are in medical, like Press Ganey, you live and die by the Press Ganey. I think there's two things that we measure success on, and the number one is the fact when we are able to make that connection, when ACS does a warm handoff, when we partner with someone, and you know it may start out that I'm sitting 500 yards from them, and then by 6 months later I'm actually sitting next to them. For someone in severe mental health, it may be that they come and find us because we have very distinct trucks and ACS has very distinct cars. That's on the patient relationship side. But I want to talk about the system side because I think in medicine and in the hospital systems, and if anybody has these thoughts too, catch me afterwards, when your system starts recognizing that you make a difference and they're like, hey, call Lindsay, or hey, call the mobile medical team, or the main psychiatrist in the jail is calling me for advice on how to care for this person better, that to me tells me we're doing something. So I would love to say that we're doing a more formal evaluation. I think we're going to get there, but those metrics we're still gnawing on, and we'll be partnering with ACS probably on that reflective piece. But again, it's the fact that they're looking for you. And they want to see you and they trust you. And that, I don't know how you capture that in data. That's that human part that AI will never, ever replace. And we have to remember that.
Yeah. It also reminds me, as you all are talking about there's some pieces about evaluation that are pretty out of our control, right? How connected to the public safety system we are as behavioral health first responders, there's this piece of, to really know our impact on the system, we have to get some more data from some other places like the police department. And that gets a little dicey sometimes, right? And, there are other ways to look at the successes of these programs. I don't know if you guys saw the video earlier of the family that was telling their story from our BCR program in Minneapolis. It was at the beginning of the day, I think. Yeah, I missed it, but I heard about it. Those sorts of things really show the success of programs and responses like this. Those stories. So there is this way to talk about and think about success that do not involve that data, and any community member who has used these services, as well as people who are members of the mental health community or the law enforcement community even, can tell you about that. They can tell you stories about it. But really, in order to get that true impact, there's got to be, if anybody has any ideas, I love to hear it, but convincing some players to give information that they are hesitant to give for probably a variety of reasons, probably some of them very legitimate and probably some of them that make no sense. So we do need police data, and it's hard to get.
I hear that,
Yeah.
for sure.